An 18-year-old female patient comes to the physician for amenorrhea. Her parents first believed she was a late bloomer, but are now concerned since menarche has still not occurred. Physical examination shows a female patient standing 170 centimeters, 5 feet 7 inches tall, with breast development Tanner stage 3, but scant pubic hair Tanner stage 1. Luteinizing hormone concentration is 47. Follicle stimulating hormone is 8, and testosterone is 1500 nanograms per deciliter, normal range 300 to 1200. Which of the following best describes this patient's most likely condition? Choice A, deficiency of 17-hydroxylase enzyme in the adrenal glands. Choice B, inability to convert testosterone into dihydrotestosterone. Choice C, inactivation of the SRY gene. Choice D, defective hormonal receptors. Or choice E, error in chromosomal separation during meiosis. I'll wait 5 seconds and answer the question. So we have a female presenting patient here with scant pubic hair despite breast development, with high LH, normal FSH, and high testosterone. This set of findings is highly suggestive for androgen insensitivity syndrome, which are patients with an XY genotype but present as female because they lack the receptors for androgens, as the condition name implies. Choice D is the correct answer. So the body develops the external male genitalia in response to androgens like testosterone. So because in these patients they don't have the receptors for androgens, the male external genitalia do not develop, which leads to the female presenting patient you have here. And of course, these patients almost always identify as female. And because androgens are also responsible for pubic hair growth, you will find these patients present with amenorrhea a lot of time, but they will have low development of their pubic hair. And because they're completely lacking in the androgen receptors, as mentioned, that includes the negative feedback receptors in that entire endocrine pathway, right? So they'll actually have very high levels of LH along with testosterone. But these patients do have testes, so the LH and FSH going to these testes will still cause inhibin to be produced. So they will still have the negative feedback from inhibin, and therefore FSH will be normal most of the time. And as far as breast development goes, it's because even though these patients don't have testosterone receptors, they're still making lots of testosterone, as mentioned, and this testosterone can still be aromatized into estrogen, which drives breast development. So, as mentioned, since they don't have androgen receptors, they present as female from birth, but they will have a blind-ended vagina with no internal female reproductive organs. So they won't have a uterus, they won't have fallopian tubes or anything like that. And this is because they still have the SY gene, right? Which is what causes the degeneration of the Mullerian structures during embryonic development. And as mentioned, their gonads still develop into testes, which stay as inguinal testes, which after diagnosis will usually be surgically removed after puberty because they are a malignancy risk. Now, it's important for you to be able to tell the difference between androgen sensitivity syndrome and various other conditions, which can cause either ambiguous gender or just abnormal development of their sexual characteristics. And a lot of this has to do with the lab values. So let's look at some of the wrong answer choices here to see some of the differences. So choice A, deficiency of 17-hydroxylase enzyme in the adrenal glands. Now this is of course referring to congenital adrenal hyperplasia, specifically the 17-hydroxylase deficiency type. So, quick review of congenital adrenal hyperplasia. 21 hydroxylase deficiency is the one with high androgens, because remember, at 21 you have more sex, at 17 you have more salt, and the 11 hydroxylase deficiency you kind of have both at once. So, as mentioned, the 17 hydroxylase deficiency has more salt because it is a deficiency of the ability to form androgens in the adrenal glands and elevation in mineralocorticoids like aldosterone. So because in these patients you get a ton of aldosterone, what happens is that you have hypertension and hypokalemia as typical symptoms. Now, if 17-hydroxylase deficiency happens in an XY patient, you have a deficiency of androgens, as mentioned. So in XY patients, it can result in either a female presenting or more often ambiguous presenting patient. Now, in this patient, you don't have hypertension or hypokalemia, right? And a completely female presenting patient with congenital adrenal hyperplasia from an XY with 17 hydroxylase deficiency is very atypical. Usually it's ambiguous genitalia. And of course, in this patient, we see high testosterone, whereas 70-hydroxylase deficiency would have the opposite. They would have low testosterone because they can't form androgens in the adrenal glands. Choice B, inability to convert testosterone into dihydrotestosterone. This is referring to a 5-alpha reductase deficiency, where you cannot convert testosterone into dihydrotestosterone. Dihydrotestosterone is very much responsible for external development of the genitals in XY patients. So patients with 5-alpha reductase deficiency and therefore a dihydrotestosterone deficiency will often have ambiguous genitalia. Sometimes they'll actually be completely female presenting. In those patients that present completely female at puberty, they will start to have penile growth because there's a surge of testosterone. Whereas in patients with androgen sensitivity syndrome, that would never happen because they don't have the receptors, right? They just don't respond to testosterone at all. Another big giveaway for 5-alpha reductase deficiency patients is that they will have normal pubic hair development because, as mentioned, testosterone is responsible for pubic hair development. So, in patients with androgen sensitivity syndrome, like this patient in the question, they will have scant pubic hair, whereas 5-alpha reductase deficiency patients will have normal pubic hair. Choice C, inactivation of the SRY gene. So I mentioned briefly earlier that the SRY gene, if you remember your embryology, is the gene that causes Mullerian structures to degenerate during embryonic development. An inactivation of the SRY gene can result in Swyer syndrome, which again is an XY patient that is female presenting. And uniquely among a lot of these sex determination conditions, because the SRY gene is defective, and like I mentioned, the Mullerian structures never degenerated because of no signal from the SRY gene. These patients, even though they're XY, actually have a uterus and actually have fallopian tubes. They might be underdeveloped, but they're there. And typically they have streak gonads, which results in a deficiency of all kinds of sexual hormones. So, contrasting with this patient, patients with Swyer syndrome typically would have low testosterone and underdeveloped breasts. Finally, choice E, error in chromosomal separation during meiosis. Obviously, this is referring to chromosomal non-disjunction, which can result in Turner syndrome and Klinefelter syndromes, the former being just XO and the latter being XXY. Both you should be pretty familiar with. Turner syndrome patients would have short stature, delayed pubertal development. Webbed neck is one of the buzzy things they like talking about, and cardiac abnormalities like coarctation of the aorta. Obviously, contrasting with this patient here who is taller and still has breast development. And contrasting again with Klinefelter syndrome, which typically has a patient that is taller and has gynecomastia, but they usually have underdeveloped external male genitalia and not female genitalia. If they don't have inguinal testes or cryptocortism, they will probably have smaller than average testes. They will also have very high LH and FSH because the body is trying to signal to these underdeveloped testes to release hormones, but it can't do it very well. So they would have low testosterone, high LH, FSH, as opposed to this patient who has high LH, high testosterone, low FSH. So bringing it back to this patient, if you remember your principles for how the central axis works, then for a lot of these questions, you can actually reason through it. Because, for example, this question, what did I tell you? I told you he has high LH, high testosterone, normal FSH, but they're presenting as female. So this tells you that the body is producing a bunch of testosterone, and for whatever reason, the body is not responding to that testosterone. And the only answer choice here that makes sense with that is defective hormone receptors. Because for every single other one of the answer choices, if I had really, really high testosterone, then why would I have scant pubic hair? That doesn't make sense. So I'm not telling you not to hard memorize stuff sometimes, but for a lot of this, it's about you understanding the concept. I hope you found this video helpful. I'll see you in the next one.